All right, so, okay, welcome everyone to this Wednesday webinar. The topic today is getting hospital leadership on board, and we'll have Sherry Pitts and Renee Simpson from Merit Health Women's Hospital speaking, as well as Jan Waddell from St. Tammany Parish Hospital, and then Dr. Lori Feldman-Winter, who's one of our CHAMPS physician champions. Just a reminder that the webinar is being recorded, and to mute your line if you're not speaking, and don't press hold because we'll hear your hold music. Okay, first I just want to do a quick CHAMPS announcement. This is actually the last webinar of the season, and we plan to start up again in the fall, but you can check our CHAMPS website for updates in the meantime, and we'll let you know when we start up again, what our schedule is. We have some upcoming trainings in Mississippi and Louisiana, the 4-hour clinical skills training. We have one at Olive Branch on July 7th, and you can register using that link or go to our website for more information. And we have one at Kenner on July 26th, and we'll open registration on Friday. And then we have a 15-hour didactic training at Merit House Leslie. That's 3 days, July 18th through 20th, and registration for that one. But yeah, you can get more information on our website too for that. We also wanted to remind everyone we have CHAMPS Baby Cafes open in Mississippi and Louisiana. They're open every Wednesday, and you can also get some more information on our website on those as well. Just wanted to give a quick reminder of those. And then we have 2 conferences coming up in November. The first one is on the 14th, the Systems for Success, the Baby Friendly Hospital Initiative in the USA. And that one's focused on systems that are working towards baby friendly. And then we have the Mississippi CHAMPS Conference on that Thursday for all the Mississippi and Tennessee CHAMPS hospitals to learn and work together for that day. And we'll have registration opening soon for that. Okay, so we can get started on the webinar. First, we have Sherry Pitts and Renee Simpson speaking. And the objectives for this webinar, by the end, the participants will be able to describe why it is important to engage their hospital leadership in the Baby Friendly Hospital Initiative and be able to state ideas for how best to reach out to and work with hospital leadership on baby friendly designation. And I will pass the user, where did they go? Oh, there they are, to Sherry.
Okay, thank you. I'm Sherry Pitts, and I'm the CEO of Merit Health Women's Hospital. I wanted to open up today by telling you a little bit about the history of our hospital. Women's Hospital opened up in 1975. And it was opened as a small boutique hospital geared toward women's health care. A small group of physicians moved out of Jackson to a suburb and opened up the hospital so the women would have a more private, personal experience when having health care. And that included surgery, deliveries, and a NICU, one of the first NICUs in this area.
Do we have the next slide, Rebecca?
Can you see it on your screen? I made you guys the presenters, but I can move it if you
can. Okay, so I see. Gotcha. Technical difficulty here.
If you guys can't do it, Rebecca can move it for you.
You're not able to move them. Sorry.
Okay. I can do it. Here, I'll bring it back to me.
Okay.
Okay. Okay. Do you see it now?
Yes, we do.
Okay.
So since we opened in 1975, we have been on a journey that's committed to women's health care, and we now are part of the for-profit system known as Community Health System based in Nashville, Tennessee. And the state of Mississippi has a network of 12 hospitals that are known as the Merit Health System. And we are Merit Health Women's Hospital. And we are still committed to caring for women and a few good men along the way that have general surgery here. And we still offer full services for the females. We don't operate an emergency room or an adult ICU here at Merit Health Women's Hospital. So that's a little bit of our history, and I'll let Renee talk about our baby-friendly journey, and I'll chime in along the way.
Hi, this is Renee Simpson. I'm an IBCLC here, and when I came on board, I was a new IBCLC. When I came on board to this process, I need to say, I've been here in newborn nursery since 1998. Became an IBCLC about 3 years ago. And when I took over this process, the OB educator had resigned. She was going on to teach in a nursing school. So I was a new IBCLC. I took over the lactation clinic here that we have, and then I heard baby-friendly and the word champs, so I had a huge learning curve. Ann had come and the team had come. I wasn't in on that meeting, and then when our educator left, she sat down with me, and all I remember was the word MPINK. That's the only thing I could remember that she said as far as baby-friendly. We had talked about the skin-to-skin. We talked about rooming in, so I was familiar with some of that just over the years of being a newborn nurse in the nursery. So I sat down and I thought the first thing I needed to do was decide what is baby-friendly, what do I need to do, what is my role going to be. So I looked at our MPINK scores, first of all. The next slide, if you can do it, Rebecca, and then the next one, I'm sorry. I looked at our overall score. 2013 is the MPINK that I had access to. Our overall score was 78%, and I thought, well, that's pretty good looking at, Mississippi scores, national scores. And so then I started kind of breaking it down and see what were our lowest scores. And our lowest MPINK scores were in the routine infant procedures that were done in the room. Our babies were still coming back to the nursery in the morning. Our neonatologists, we don't have pediatricians. We have a staff of neonatologists that are in private practice that work in our hospital. And they were seeing the babies in the nursery in the morning. We'd have them all lined up, and they would do all the exams. We would do circumcisions. So babies were in the nursery most of the morning. Then I looked at our non-breast milk feeding. Our scores on that were about 30%. And I thought, well, I know a lot of our babies, just from working the night shift and the history, are still getting formula. So some of the numbers I did kind of question. And our breastfeeding education was a low score. It was around 30. We really didn't document how we taught our moms, what we taught our moms, what our moms understood. We just we had a great lactation department, I will say that. We've always been very good about helping our moms breastfeed and being there for them. But there really wasn't any documentation as to how well we were doing and how well the moms were understanding, who was getting formula, why were they getting formula. So I looked at that, and I said, well, we can do better on that. So then I think it's the next slide. I decided to make a notebook. I went to the Baby Friendly website and printed out everything on Baby Friendly USA that was possible to print out, and started just looking at it, what do I need to do, what is step one. The CHAMPS website was very helpful. And when Ann, you and Laura and Kirsten had come in the meantime, too, while I was still working on this. And Laura and Kirsten were great. They actually sat down and looked at my notebook and said, okay, this is a good start. And so I knew I was kind of on the right track with that. The CHAMPS webinars, the archived webinars have been a huge help. I've gone back. I've learned a lot of information from that. So I just kind of looked at an overall picture, and you can go to the next slide, of what I needed to know, and I kind of got it organized. And I prepared a folder for Sherry, made an appointment with Sherry, and I wanted to have everything lined up so that she wouldn't have to search it and just rely on what I was telling her. So I printed out the 10 steps, the International Code of Marketing of Breast Milk Substitutes, because I knew that was going to be a big thing for us in purchasing formula, that was going to be a part of it. I printed out the sample CEO letter and the fee schedule and put that in a little manila folder. And we just sat down and looked at it, and I thought we would just set up a target date, and Sherry said, well, let's just do this while you're here. Let's get on the website. So we got on the Baby Friendly website. We registered that day. Sherry did the CEO letter that day, and we were off. So, but it took a lot of this didn't all happen in one day. I better back up. We had conversations back and forth, but it was really like, I don't know, we need to do this, or how do we do this? So it was just a matter of sitting down and saying step one, step two, step three. So that's kind of how I did it.
And I will add that, and this is Sherry again, that I had heard about Baby Friendly, and I knew we were a CHAMPS hospital, and I've had been around and on the periphery of this, but once Renee took the bull by the horns, as we say here, and became engaged and organized with the process, and our visit from Ann and her crew helped really kind of boost that some. We got it in gear, and we started in earnest on our journey. I'm probably easier to get in touch with because we're a small hospital, and women's health is our priority here. We don't do parts, we don't do psych, we don't have other service lines. So, and that's why it's my mission to learn as much as I can about this. And Renee, along with Linda Atwood, our chief nurse who's here, have pushed me along and educated me. They really are the experts on this subject. And again, I'm seeking as much knowledge as I can so I can be involved and supported along the way too.
And next slide, Rebecca. And on this one, I said just continue to learn because I'm continually learning. And I do want to be a good resource for Sherry and Linda. So I ask a lot of questions. If I'm not clear on something, I will email Laura. I will call Baby Friendly. I'll email Baby Friendly. So there are a lot of resources out there. And just continue to know everything you can so that you can be help to your administration.
This is Anne. I just want to chip in. I just have enjoyed working with you guys so much and seeing like how Women's has really sort of come on board from the beginning of not, when we went there not knowing very much, and now suddenly like you're leading the initiative really for Merit Health, and it just speaks to teamwork is what my first thought is there. People ask me what works for these sites, what is the one thing that stands out for these sites, it's leadership and teamwork. So you guys are doing that, and you've got Sherry, who's the CEO, very much involved in the entire initiative, and that's making a huge difference. So thank you, and thanks for your contribution.
Thank you.
Do anyone have questions before we move on to Jan? Anyone have questions for Sherry or Renee? Okay, we can ask questions at the end. Do you want to move on to Jan? Thank you, Rebecca.
Okay, can y'all hear me?
Yep.
This is Jan. Can y'all hear me?
Yes, we can hear you.
Yes.
Oh.
Yep.
Okay.
Yes.
Okay. Well, we'll get started. So I'm Jan Waddell. I'm one of the staff nurses at St. Tammany Parish Hospital, and as I was sharing with Ann and Rebecca before we went online, I'm proud to say I just passed my IBCLC for the third time in the past 20 years. So, okay, y'all can go to the next slide for me. So, St. Tammany Parish Hospital is located in Covington, Louisiana, and St. Tammany, the organization was instituted back in the 1950s, and it is a not-for-profit hospital. Maternal child services is one of the many services it offers. So we have pediatric services, we have emergency room, we have surgery, we have med-surg patients. So we are a portion of this hospital. We have a 19-bed LDRP unit, and we do approximately 1,750 deliveries a year. Now, one of the challenges that we face is we do not do couplet care. However, our LDRP, our L&D, our postpartum, our nursery, our NICU are all physically in the same area. So logistically, there's not a whole lot of steps that you have to take to get from one area to the other. We do have a level 3 NICU, and some of the nurses are cross-trained. For example, our NICU nurses have to be able to work in well baby nursery. Our pediatric nurses have to be able to work in well baby nursery. L&D and postpartum, as for that cross-training, the L&D nurses are also able to do postpartum. But one of the challenges is that they are still separate entities, and even though we have done and continue to do a lot of education, some of the nurses still see patients as separate entities rather than as a couplet or as a dyad. So that is one of the major hurdles that we're still working on. Next slide. So just to give you a little background, Lactation Services was instituted in 1996. I came to work at St. Tammany in 1992 and began studying in 95 and then passed my first round of boards in 96. I was, for the first 7 years, the only IBCLC that St. Tammany had, and I'm proud to say now that we currently have 5 of us on staff. And basically, I serve, as I said, as a staff consultant and the BFHI team leader. Now, for those of you who are just recently embarking upon your journey for baby friendly, it takes patience. It's like that ant working its way up a hill, because I first introduced the concept of BFHI to management 15 years ago. So here I am still, many, many years later, still trying to see this come to fruition. Next slide, please. So I began collecting statistics on breastfeeding initiation back in 1999, really prior to anything that was required of us from Joint Commission or prior to the institution of MPINC. And at that time, we had like a 56% initiation rate. And that was really 3 years after I had instituted, all the policies and all for lactation services. So prior to that, it was probably much lower than that. we entered the baby-friendly pathway this past December with the much appreciated backing and assistance from CHAMPS. And just to bring you up to date, as of December of 15, our initiation rate is now almost 80%, and our exclusivity rate, and these are the definitions that are by Joint Commission standards. An exclusivity rate is, I meant by what's considered baby-friendly standards, and our exclusivity rate is now 59%. We have a lot of baby-friendly concepts in place, but we have much room for improvement before we can really advance further along in our pathway and you know, really get serious about baby-friendly coming in and doing an assessment at St. Tammany. Next slide, please. So, the challenge with engaging leadership. One of the big challenges, as I said before, we are not just a maternal child hospital. So, our management at St. Tammany has a lot of balls they're juggling. They have a lot of priorities. And one of the big challenges is getting on that list as being one of the top priorities. So you have to be a little creative in really figuring out what is going to get leadership's attention. And so where I basically started, or where we as a lactation team basically started with my immediate core group of managers, is to try to stress the benefits that administrative management would really be interested in, what would really catch their attention. And so basically what we began informing them of, and how I did this was, I basically worked through my maternal child director, and my maternal child director then works through the Vice President of Patient Care Services, who also works, who communicates to the CEO and the other administrative management team. But the basic things that I was honing in on is that, you know, from all indications, we understand that JCAHO may be requiring this in the coming future. And we also have informed them that the CDC is scoring hospitals and publishing these scores online for anybody to be able to go in and look at. Our last scores were less than stellar. For some reason, I don't know why, but we were not surveyed in 2013. We were in 11, and the scores were less than stellar. And I wrote a very long letter to my director of Women and Children Services at that point in time, telling her what I felt like needed to be done to improve the scores. But most of the things are all things that we are still working on for baby friendly, such as rooming in, skin to skin as quickly as possible after C-section. The other thing that I've honed in on is other indications that we're getting is possible ties to hospital reimbursement. Also emphasizing that it's not just a breastfeeding initiative, that this is an initiative on taking care of mothers and babies irregardless of how they're feeding. Because a lot of physicians and management alike are under the impression that this is just a breastfeeding initiative, and it's not. It's much, much more than that. St. Tammany is very, very, very pro patient care services. I know that they, we have just recently been granted some type of an initiative for stroke patients when they come in. There's another initiative that they're working on for trauma patients. So my emphasis to management is just as those things are important to those services, BFHI is as important to our maternal child patients and customer service and the care that we give. Another thing I hone in on is particularly with the initiation of immediate skin-to-skin for vaginal deliveries, and as soon as mother is physically awake and capable in terms of C-section, by instituting this skin-to-skin appropriately, as by Baby-Friendly's definition, you're going to thereby decrease admits to the NICU, which is cost saving. Anything that I can point out to them that is cost saving to the hospital gets their attention. Another big thing that I let them know is about the grant funding through CHAMPS. CHAMPS has helped us enormously. We also have COFECTIVE here in Louisiana that is, has been another wonderful resource to us, and between CHAMPS and COFECTIVE, we have gotten started with a lot of our education for our nurses free of charge. So that has been a big help. I mean, basically, I've told them we can either wait years and not do this right now, or we can get on the bandwagon right now where funding is available. The other big thing is that we have a local competitor, which is, I would say the two hospitals are within 10 miles from each other, and they're on the pathway to Baby-Friendly. So a little local competition can be a very, very good thing. I've kind of, I have a lot of communication with the lactation consultant at the other hospital. We sort of brief each other on what progress we are making, because instead of being an entities that are trying to work against each other, we are trying to be friendly competitors and roll things out at the same time, so that one physician can't say, or a group of physicians can't say, well, I don't like the fact that you're doing this at this hospital, so we're going to go down the street to the other hospital. Because guess what? Down the street at the other hospital, they're doing the exact same thing. So we formed kind of a friendly alliance, but at the same time, we're letting our upper management know, hey, this is what such and such is doing down the street. So if we, want to be able to compete with patients that are very savvy in doing research on where to deliver their babies, then we need to get going with this. Next slide, please. So, as for where we are now and in the future, 6 months into St. Tammany being into the BFHI pathway, we've had a 6% increase in breastfeeding initiation. I don't think that's too bad, 1% each month. I've had a 0.5% increase in breastfeeding exclusivity. We have just entered the second stage or phase of Baby-Friendly, which is the development phase. And hopefully, I'm keeping my fingers crossed, I'd like to be through it by the fall and then on to D3. There's still a lot of work that needs to be done with senior management. We have to gain their support for controversial hurdles. One of the biggest hurdles that I'm facing that a lot of my hospitals in the New Orleans area said was not that big of an issue for them, is 24-hour rooming in. Basically, it's physicians, pediatricians rounding in the room. Pediatricians rounding in the room. So we continue to work towards that. One of the things that I did, and I know CHAMP has a copy of it, and they're welcome to share it, but I sent a letter of documented research for rooming in to one of my champion physicians, and he in turn shared it with our Chief Medical Officer as well as our CEO. And basically what I did was went on CHAMP's website, and they have wonderful resources as to the links to all of the major associations that endorse BFHI and rooming in. And so this letter has been sent, as I said, to our CEO, along with statements, specific statements from the American Academy of Pediatrics and Joint Commission, because as I told our physician, I can give you article after article after article, and you can show that to other physicians, but they're going to find something wrong with that. So you have to really go for something that the docs and management, upper management, senior management, are going to find as concrete evidence, such as American Academy of Pediatrics or JCO, you know, I mean, or CDC. You can't get much better than that. So that's pretty much where we stand at this point in time. And any questions? Okay.
Okay, we can have more questions at the end if anyone thinks of something.
Okay.
And I'll pass it to Lori. I think it
Great.
should be.
Thanks so much, Jan, and thanks, Rebecca. Just a little background about who I am and what I hope to do in the next few minutes, closing out my portion of the webinar, and definitely we want to save time to have a dialogue, questions, conversation about these issues around leadership. So I'm delighted to serve as the physician lead on the CHAMPS project. I've met some of you in person, and I'm just really excited to be part of this project because I think this is really a great illustration of transformational change and how to bring leadership on board. I'm a pediatrician, so I do definitely hear those concerns that Jan shared about pediatricians not wanting to change in what they do and what they've done for many years in examining babies in what we used to call nurseries. We've decided to change the name to make it less desirable, so we call it the Neonatal Observation Unit in our hospital, and we've really championed the cause of doing more patient-centered, family-centered rounding in the room. So I am a pediatrician. I work in a urban, underserved setting in Camden, New Jersey, and I spend some of my time as an adolescent medicine physician, so I take care of teenagers, the time of life when lots of change is happening, so love change in that way. I also spend some of my time as a professor at the medical school teaching young and very impressionable future physicians, and that's very exciting. And I serve as a leader in our division as well as a leader within the medical school. And as I said, I'm delighted to serve as the lead on this project for the physicians. I'm going to describe for you a model of change that was developed by John Carter. So a little background on John Cotter. He is actually educated as an engineer from MIT and then went on to study business at the Harvard Business School and very quickly rose through the ranks as professor and really head of the Division of Leadership within the Harvard Business School. And really, John Carter's major contribution to business and the engineering science of change is to describe the change process as first starting out slowly. You know, there's the early adopters, but really change kind of begins rather slowly with some trepidation and a lot of fear. And then slowly but surely gaining momentum, and so there's this sort of middle phase when kind of the middle of the road adopters get on board, but then very quickly experiencing rapid acceleration or exponential change. And this is what we really refer to as the curve. So one can be, as we often say, ahead of the curve, and so those are the early adopters, folks like Boston Medical Center that became baby-friendly designated way back in the 90s, and then those that ride the curve or ride the wave, so to speak, and really that is what's been happening over, I would say, the last 10 years or so with the Baby Friendly Hospital Initiative, really understanding what's involved and really getting on board. And now we're really experiencing the time of exponential change. This is really a period of time unprecedented in the baby-friendly world in the United States, where we see a rapid acceleration of the number of hospitals that are indeed becoming designated. And I think, you know, to speak to, I think it was Jan's point about, you know, doing it now and not waiting to come back around and put it on the back burner, that if one doesn't get on board during the time of exponential change, you find yourself in the position of, as we call it, behind the curve. And so there are many incentives, and I think that there's this concept of the greater good, and I'm going to hopefully describe some of that as we go through each of Kotter's 8 points of change. But I think that we're really getting to the point where hospitals that are putting the Baby Friendly Hospital Initiative on the back burner, they're going to find themselves truly behind the curve, because it's exciting, actually. It's exciting for all of us that are doing this work that we're actually riding this exponential part of what John Carter refers to as the curve. So let me go through quickly these 8 points of transformational change, and in doing so, also point out the red stop signs to the right and what Professor Carter has helped us do in identifying the risks of any one of these 8 steps. And then I'm going to go through them a little more thoroughly in the context of the BFHI. So the first is establishing the sense of urgency that, you know, we're really in this exponential point of the curve. We really got to do this now. And in doing that, we have to actually make the case. So as Jan pointed out, using the evidence from the American Academy of Pediatrics, Joint Commission, and others to say, you know, we really need to do this. Here's the evidence. The risk is not making that case in a sufficiently compelling fashion. So I'll come back to that. Forming a powerful guiding coalition, CHAMPS has actually helped you do that. And by doing that, hopefully all the hospitals in CHAMPS really do have a credible and cohesive team. If the team's not credible, if they produce evidence or say things that are, you know, not really in alignment with the BFHI or don't have evidence or not really cohesive, there's, you know, not true division of labor, then that's certainly a risk in forming this real powerful guiding coalition. Creating that vision, the risk being that the vision itself is vague or that there's, you know, not enough of that vision to make the case to become motivated to actually make the changes necessary. Communicating that vision, Kotter talks about not communicating by a factor of 10. So basically over-communicate. If you think you've communicated enough, well then just go back and communicate it 10 times what you were doing. in the past. So you can't really talk about it enough to really effectively communicate all the different changes that are necessary for BFHI. The fifth point is empowering others to act on the vision, and to do that, you have to neutralize resistance, and there will be resistors. I mean, as a pediatrician, I know there will be pediatricians that say, I'm just not doing that. And so you have to figure out ways to neutralize that. Planning for short-term wins. Quality improvement helps you do that, and I'll illustrate that in a little bit. Really not allowing those small little wins to happen by chance. So you're going to orchestrate your small wins. Consolidating those improvements so that more change can happen even beyond that. So I know that all of the hospitals within CHAMPS have already accomplished some elements of change, but we can't stop there. We can't declare victory too soon. And even designation, even becoming a baby-friendly designated hospital is not the point of victory. In fact, this is a continuous quality improvement process. So really, victory is all the time, but it's always something that we yearn for in the ideal sense. And finally, really institutionalizing or changing the culture so that doing anything but BFHI practices really become almost uncomfortable. So let's talk about, in more detail, operationalizing the Cotter's messages. So first, creating the sense of urgency about changing maternity care practices, especially with regard to the populations that you serve. So if you present your leadership with data that points out the fact that there are disparities in care, well, you can't argue with that. You know, you can't go to bed at night to think that it's okay to have these vast disparities in the way you deliver maternity care. It shouldn't be that only women that come with a birthing plan can actually have skin-to-skin care, can leave the hospital exclusively breastfeeding. In addition, using the triple aim, and I think Jen actually talked about the triple aim without calling it that. So what is the triple aim? The triple aim is this framework that Don Berwick from the Institute for Healthcare Improvement articulated that really has been the driving force behind the Affordable Care Act and behind healthcare in this day and age in the United States, and really how our healthcare systems are evolving. So the triple aim involves providing effective care, evidence-based care, so that we improve outcomes. So health outcomes are one key element to the triple aim. And that's easy with the BFHI. You can make that argument compellingly because we know that if the BFHI is put into place, you have increased exclusive breastfeeding, and there's a whole myriad of health outcomes that are associated with increased rates of exclusive breastfeeding. The patient experience. This one's tough, and I will tell you that hospitals are now being held accountable. Your foot is to the fire in terms of the patient experience. I know you all know what HCAHPS scores are, and you need to score 5, you know, on every one of those parameters. There was a great study that actually showed that the best way to do that is to improve communication, particularly among nurses and doctors. And so if the nursing staff and physician staff are actually implementing the 10 steps, what they're doing, in essence, is more effectively communicating about maternity care practices, because within each of the sub-steps of the 10 steps are elements that require more effective strategies for communication. And you will find that your HCAHPS scores ultimately will go up, and so patients will be more satisfied. We know that rooming in is one way. Rooming in a way that effectively coordinates care, that makes care patient-centered, the whole family being the focal point of that care, is a better model for patients and families, and they, in fact, enjoy that care better. And then finally, costs. We can't talk about the triple aim without costs, and we know also that there will be costs associated with not becoming baby-friendly in the future. Pay for performance is really one mantra that the healthcare system is holding up there, and whether that's because of core measures, and the core measures really will have a price tag associated with them in the future. Some states, such as Mississippi, have the payer insurance companies like Blue Cross and Blue Shield that are saying, well, in order to gain Blue Cross distinction, as we talked about with Renee before the call, in order to gain that distinction, you need to become a baby-friendly designated institution. So it's easy to talk about the triple aim, and that will definitely resonate with your leadership when it comes to the importance, that sense of urgency to become baby-friendly designated. Forming that powerful guiding coalition, as I talked about, it's not just forming it, but it's really providing the necessary resources. So budgeting for that steering committee, that task force, to get together on a regular basis and actually do the work that's required to implement all these changes. Creating a vision. So what does a baby-friendly hospital look like? I encourage everyone to take a field trip and actually go to a baby-friendly designated hospital to see what it looks like, see what it feels like. It should be uniform. We know from the patient safety world that the more variation in care, the more susceptible that care is to safety issues. And so when you think about the maternity care practices that you roll out that are consistent with the 10 steps, it should be the same for everybody. So anybody who delivers at that hospital should really be able to describe that experience similarly. And I remember a story in a local hospital that really had a reputation for providing stellar maternity care for mothers. And what did they put up there on a pedestal as being the thing that everybody could talk about? Well, it was having the steak dinner in the penthouse, and that was supposedly, the optimal way to help mothers, in their delivery experience. Well, clearly we know that that's not the case, but that was the experience. That was the vision, that women had, that people wanted, when they decided to deliver at this hospital. Well, certainly we can do better than that. So communicating this vision, and I talked about over-communicating by a factor of 10. I will tell you that probably one of the most heavily worked people on our task force is the person from public relations. She's always creating videos and stories to publish in the hospital newsletter to go out to both the staff at the hospital as well as the community to talk about what we're working on. So the worst thing is to not communicate and then have all these myths and mysteries and misinformation bubbling up. So you want to be clear about what you're doing. Empowering others to act on the vision. So to do that, you really have to make the system the easy way. So the electronic health record should be defaulted, as Emily Taylor has educated you all to do. The easy way to document should be the way that's most consistent with the 10 steps. And there's this concept of rounding. We can talk about it after I'm through and have a conversation about rounding. Rounding means leadership goes to the front line and just asks, what are the good things that happened today? What are the bad things that happened today? How can I help you how can I help you so that you can do your job more effectively? Are there things that you do that are really not at your skill level? Someone else should be doing it, someone at a lower skill level or at a higher skill level. What are the obstacles? What stands in the way? And I'll say that kind of huddling and having these red light, green light reports and really getting back to people that are stepping up to the plate and doing a good job will help create that culture for change. Planning for those short-term wins. So how do you do this? Well, rolling out PDSA cycles. You're going to do these little PDSAs with skin-to-skin after a C-section, as I heard. So cesareans, more challenging for sure than vaginal deliveries and getting babies immediately skin-to-skin. But if you do it and you get good feedback, that's a short-term win. Celebrate that, tell the story, put it in your newsletter, and then ramp it up so that it becomes more systematic. And that's where you begin to consolidate these improvements. So you consolidate by replicating different staff, different times, different days of the week, and then auditing. Don't be afraid to audit, even if the audits aren't going to look so good. You have to start somewhere and begin to capture the data that's going to help continuous improvement. Finally, hardwiring. So you're going to anchor these changes into your policies. We're working with you all the time in rewriting some of your policies, typically not just one policy, but you'll have all these other supplementary policies that will have little details that affect the exclusivity of breastfeeding, that affect whether or not babies can stay with their mothers continuously in a rooming-in environment. And so think about all the different policies that can affect the 10 steps. And ultimately, once these steps are fully implemented, it will feel weird. It will feel uncomfortable if practices are undertaken that are not consistent with the 10 steps. When you start to see a baby in a separate place that we used to call a nursery, it's going to feel icky because it'll be like, oh, why is that baby in the nursery? Babies are never in nurseries in this hospital. It just will feel weird. And that's when you know the culture has changed. When you begin to just not even have seen bottles around for days or months. And any time a supplement is given, it's given in an alternative feeding method, a cup or a syringe. And that just becomes the standard of how things are done. And then seeing a bottle and you're like, oh, what's that doing there? It really should feel uncomfortable to do anything but the 10 steps and fully implementing the BSHI. So I've left a few minutes for dialogue. I'd love to know if anyone has done rounding and what your experiences have been, doing rounding, and if anything else that I talked about, stimulates any more thought. And I want to go back to one thing that Renee said. She said that we're all learning, but really we're all teaching and we're all learning all at the same time. And that's really a great mantra to have, that for what we know, we can teach, but then we're also learning continuously. Thanks.
Thanks, Lori. Does anyone have any questions for anyone who presented today?
Lori, I know you've sort of written some materials on leadership. Do you have the top 2 or 3 tips for those people who are on the call today who may be struggling to engage their leadership, based on the work that you've been quoting and baby friendly? Give us if they go back tomorrow and say, okay, task force, we're going to do these 2 or 3 things. What do you think for this specific? Let's assume we're sort of early on in baby friendly, and basically someone signed the CEO letter. What can they do next week to get some more involvement? They've got the CEO letter, but people haven't really bought in.
Right. So every CEO of every hospital in this country is looking at their HCAHPS scores. I just can't imagine they wouldn't be, because they're going to lose money if their HCAHPS scores are in the toilet. So framing this whole process in the triple aim and pointing out where implementation of the 10 steps will help patient satisfaction, will help their HCAHPS scores, is one thing that will get leadership attention. And then the ask. So if the teams could write down, what is it that I really want to have leadership help us do from a leader perspective? Maybe the leadership can help mobilize somebody from public relations to tell one of the good stories in their newsletter. So by asking leadership for specific finite resources to help them move this forward.
Lori and Ann,
yeah.
This is Jane. I have a comment, something that Lori said that just kind of jogged something in my mind. Our hospital has a Facebook page, okay? They're really big into Facebook. Also, there is there's a group. I don't belong to it, but I probably should figure out how I can get invited into it. It's like a closed group, but it's in our area, and basically it's for moms that want be, they want to have say-so. They want to have choices. They want to say how their deliveries are going to be. So these moms are out there, and they are communicating back and forth. Getting back to our Facebook page, the other day, St. Tammany posted a story, I don't know, on the Facebook page about one of the dads proposed to the mom after she had the baby when she was in the hospital. So I'm thinking to myself, okay, if you can put something like that on there, then why can't we put positive stories from moms on our Facebook page with possibly like, a photo of mom and baby, or mom and dad and baby, or, who have a mom and their core support group and baby, about a mom that was able to do skin-to-skin post C-section, or a mom that had a successful non-medicated birth at St. Tammany Hospital. I mean, I think that would be, because I'm telling you, patients are getting more and more savvy. They are doing
everyone.
I mean, it's not just I'm going to go to this hospital or that hospital unless it's just absolutely dictated by insurance. But they're becoming more and more savvy. And I think particularly in the generation that's giving birth now, they are so savvy with social media. I think that may be an area that has not been tapped quite a bit yet.
Absolutely. There's no question that the current delivery population is connecting in their own media, in social media, in Twitter, in blogs, a lot of blogging going on. You want to control those messages, and if you don't control those messages, then you really don't control the way in which communication is going to get out there, and you don't control the messages that you want, about these processes. So starting a blog, I mean, we have a blog, our hospital has a blog, and we have times where we have our experts available to do live blogging and live chatting with folks that are going to deliver or folks that have questions about any specific area of medicine. But definitely using your Facebook page, that's where they are. So if that's where they are, go there. Go to the place where your moms are and ask permission for the families involved in good stories that you can share. John Carter talks all the time about valuing the story, and your leadership, your CEOs, value the story as well, more than even the crunching of data points, on a run chart. Really having a good, compelling story is as important, if not more.
Well, and the other thing I think that I may approach management with is, hey, we just want everybody to know that St. Tammany Hospital is progressive, and we offer 20, I can't say, I have to put it in a way at this point in time that, doesn't cause the docs to be totally outraged, but say, hey, we do offer 24-hour rooming in for those patients for those moms and families who want it, so that to get them in the frame of mind of asking the doc, well, hey, I'd like you to make rounds in my room because, I want my baby to room in with me 24 hours, just like St. Tammany says they offer. Throw it back on the doc, I'm thinking, so they can explain to their patients why they can't round on the babies in the room, rather than making the nurses go get the baby, which is a very uncomfortable situation, and taking the babies from the room.
Yeah, that's unfair. I mean, I would just, as a pediatrician, say it's just unacceptable for the pediatricians to dig their heels in, and the leadership can help you make the case to the chief of peds and whoever's, just like everything else in medicine, if the hospital has a certain structure and you have to do something, you have to get training, they're just going to have to come on board. There's enough evidence. The AAP stands behind it. Late breaking news, there will be a clinical report coming out in September that will help explain to pediatricians how to do this safely, rooming in and skin to skin. So I hate to put the onus of responsibility on the moms, really the hospital leadership has a role in affecting how those pediatricians are providing that care.
I had a couple of ads when just that was I thought through as those ideas were expressed. One is that we did have a hospital ask us last week, would they fail Baby Friendly if one of the doctors on the unit refused to answer the questions when Baby Friendly USA came? And my response to that was, you cannot ever get yourselves in your position where Baby Friendly USA comes and a doctor won't answer the questions. And for the same rationale that Laurie just went through, the doctors have privileges to deliver babies or to see the babies afterwards in your hospital. Your hospital is investing in this. By the time you get to the stage of having Baby Friendly USA walk through the door, the hospital has invested quite a lot of time, money, effort, and policy making in this. So it's not going to be acceptable that a doctor refuses to be interviewed, and that's going to have to be addressed with leadership. It's not, you do not want to get into that position, but it's not a reasonable position to be in either. I mean, doctors can't just go, I mean, they do, but, you know, in our world, in this particular field where we're trying to do, we're not going to accept that doctors go off and do their own thing when the whole hospital's going in one direction, they go in another. So that's, you know, that's something that just can't happen. The other thing I just want to let you know, the MPINC scores for the past year, 2015, which I hope most of you have done, they will be out in September, just so you know that. And I don't, you know, we were in this conference yesterday with the Mississippi hospitals, and it kind of made me wonder, I don't know if your MPINC scores are going to go up or down, honestly, guys, because we've been working with many of you in CHAMPS to actually help you redefine your terms a little bit more strictly. And I know that some hospitals, you know, when we went around and we looked at what their MPINC report said and what they were doing, the MPINC report was tremendously optimistic. So you may not necessarily get an increased score this year if you've been making changes, because you may be being a little bit more tough on yourselves. But anyway, those I just heard, I asked the CDC yesterday, and those reports will be out in September. I kind of think we're at the end of our time here. I don't want to run over for people. So I just want to thank everybody very much for being on the webinar. It has been recorded, so you'll be able to access it through our online, our website where all our webinars are. The other thing is that we don't have any more scheduled because it's the summer, so we're going to take a break, but we will schedule them starting again in September. So just watch the website, and our hospitals will get an alert when our next round of webinars are coming up. And they're going to be much more like this one in that we're going to call on many of our CHAMPS hospitals to do the presentations. I think most of the webinar series in the fall will be you guys reporting out and you know, sharing with other hospitals the work that you've been doing in many different areas. So thank you all again, and I think that's it unless anyone has anything else to add. Okay, thanks all, and we'll see a lot of you in the summer. We're doing a lot of site visits, so I look forward to seeing many of you.